Hi, I'm Ryle Przybylowicz, a cardiology fellow from Oregon Health and Science University and part of the Circulation COVID team. I'm joined today by Dr. Gregory Roth, an associate professor in cardiology and the Institute for Health Metrics and Evaluation, or IHME for short, at the University of Washington School of Medicine. Today, we will be discussing modeling and the IHME's model for COVID-19. Dr. Roth, thank you so much for joining us.
Nice to be with you.
All right, I have a couple questions here, if you don't mind. Do you mind describing some details of the IHME model for COVID-19? For example, kind of what are the inputs involved, some of the assumptions, and the major outputs that you use in the model?
Yeah, I'm happy to talk about it. So I'm a cardiologist at the University of Washington, but I also am a research scientist at the Institute for Health Metrics and Evaluation, as you said. And over the last 2 months, the Institute has built out quite a large research team looking at COVID-19 forecasts. And so I've been fortunate enough to get to participate in some of that work. The experience that I bring is both as a clinician and then also as a disease modeler, where I help lead some of the work for the Global Burden of Disease study around cardiovascular diseases. About 2 months ago, actually, our health system, University of Washington Medicine, came to the Institute and asked for help in trying to plan for the expected coming surge of COVID-19 patients. And so very early on, we were actually focused on this initial outbreak or cluster of cases that were in King County and Seattle. And we began developing a model that would actually look at mortality related to COVID-19 and try and give some information to our own planners here as we try and figure out how to prepare. It turned out that the model was quite useful, and we began getting a lot of requests, first from other states and then from other countries as well. And so over the last 2 months, we've developed and evolved a model that does a couple things. The first is that it pulls in the number of deaths due to COVID-19 and then estimates a range of outputs. One of them is the curve of the epidemic, so trying to understand when it will peak and when it will actually decline. The second is the impact on healthcare utilization, and there it looks specifically at hospital beds, ICU beds, and ventilators that are needed by day. And so the general idea is to try and take all of the available information around this rapidly evolving public health crisis and put it rapidly in the hands of healthcare decision makers, people running health systems, governments, and things like that. One of the key differences between our model and some of the other models out there is that we've made the early decision to build a lot of this off of information on deaths. And that's simply sort of a practical decision because we know that case ascertainment is really limited by the availability of testing right now. And so we use statistical methods to estimate the future forecast, but we build it off of deaths because we think that while there are also limitations to collecting data on deaths, it's much better than the data we have right now on total number of cases.
So what are some tips for interpretation of this model for clinicians as well as policymakers who are looking at the models kind of on a daily basis?
It's really important that people understand a little bit of what the model is trying to do. Primarily, it is a model designed to put information in the hands of policy decision makers. That could be governors' offices, that could be federal or national, ministries of health, that could be local health systems or counties. And the idea is to try and integrate a lot of different information, right? So one of the things that models are useful for are trying to combine data inputs where humans are just not that good. If you went with your Gestalt guess, it's really hard to pull in the shape of the trend in deaths, plus the interactions between number of deaths and number of ICU beds that are full. And we want to try and leverage all of the available information. And that's actually particularly important because there's still very little information about this coronavirus and COVID-19. And so we really want to use some of these tools we have to make sure that we're not, accidentally blind to some important piece of information. So the idea here is to be comprehensive, to use the resources of the Global Burden of Disease Study and the kind of work we do here at the Institute for Health Metrics and Evaluation, and make sure we're being exhaustive, pulling in all of the data, and then use statistical tools to make sure that we're not accidentally, injecting some kind of bias into the whole thing, that we're not anchoring on some assumption that we have. And so, one of the goals here is to update the model continuously. And that's because we know the data is actually evolving very quickly. So one example is that the shape of the mortality curve actually looks a lot different today than what we would think it would look like from a couple weeks ago. It's much flatter, and we seem to be hanging out at the top of that curve much longer than we saw in some of the initial places where there were outbreaks, like China and Italy and Spain. And so we want to make sure that we're accounting for all of that. So, to people out there who are trying to interpret all of this, I would say, one, understand that models are complex and they're designed to use the best available data, and that we need to go back and reassess those assumptions frequently. Secondly, pay attention to that uncertainty interval. If you're a healthcare planner, you probably want to be looking at the upper range of that 95% uncertainty interval, because of course, as planners, we can't assume that everything's just going to play out right down the middle. And we want to make sure that we're prepared for, any eventuality. What this model does is it gives you sort of a range, a bracket to work within, rather than just, not knowing much at all.
What are some enhancements that we can expect in the future for this model? Are there any additional things you guys are planning on adding to the model beyond what you've already discussed?
So there's been a lot of requests coming our way, and we're working within the bandwidth we have. I think, one of our primary goals is to just make sure that we're updating the data sources as rapidly as possible. And so we've been going directly to states, working with health systems, directly to governments, working closely with the WHO, working closely with the White House, working closely with governors' offices to make sure that we're building in the data that they're generating. And then in addition, there's a lot of demand to expand our coverage. And so I believe the next step is going to be adding in Latin America. And so we've been working closely with the Pan American Health Organization to make sure that we can do that in a collaborative way. There's an interest in looking at other outputs, like the demand for personal protective gear or the demand on the healthcare workforce. There's been interest in alternate scenarios in which we start to look at what would happen if we made different policy decisions. And I think there's a real interest in going down a level from states to the county. So we're interested in doing all of these things, and we're mostly just constrained by the number of hours in the day at the moment.
Yeah, that's fair. So do you mind commenting? There's some skepticism in some quarters about modeling and data and how we use that. How valid are these kind of outputs we're getting? Any comment on kind of folks that would say that?
One of the interesting things that's been going on is this huge amount of attention that's now being focused on models. And this is even in the lay press. And so it's really surfacing, I think, a lot of ideas that have been floating around out there. One of the interesting things about using modeling in health and epidemiology is we've been doing it for a subset of the science for a long time. We've been doing it to predict health outcomes or to identify risks that drive diseases, but we haven't necessarily been using it to make big policy decisions as well as we could. And as usual in healthcare, we sometimes lag behind other fields, right? And so, most people would not want to drive across a bridge where the bridge hadn't been designed using some kind of computer modeling to test things. Most people wouldn't get on an airplane where that hadn't been done either. And so one of the things we can do with modeling is really try and test out alternate scenarios without actually having to figure out how to study something in a large population. There are a lot of constraints in large populations. One, very, very expensive, right? We know large trials run into the hundreds of millions of dollars. Two, especially for cardiovascular diseases where I've done a lot of work, long time lags, decades and decades, where you wouldn't be able to run things that long. So I think it's been really interesting to see how people's assumptions about what models can and can't do have sort of bubbled up in this environment.
Mm-hmm.
You know, what we know is that there are different kinds of models, and we have to teach people a little bit more about how we use them. So you could imagine a model that's much more like a computer game, a simulation, where you really have to know everything about the universe that it's happening in, and that can be quite hard to do. But you could imagine another kind of model, like a weather forecast. And weather forecasts, when they're wrong, we don't throw out the idea of weather forecasting, right? We have this kind of intuitive sense of what probability means in the real world. And I think that's a lot more like what our model is doing for COVID-19. I mean, for the cardiovascular community, another good example is our risk prediction models. So we know that when we run the pooled cohort model for our patients, that isn't an attempt to figure out exactly what's really going to happen like a crystal ball for the individual who's sitting across from us in our office. It's a tool for trying to sort of bring all the data together and make an informed decision. And so that's really, I think, increasingly the way we want to think about modeling, especially when we're either talking about clinical care or we're talking about population and policy decisions, is how do we bring all the data together and what's a good tool for integrating it so we can make good decisions.
Thank you so much for joining us today, Dr. Roth. For those of you that have not checked out IHME's website, I would encourage you to evaluate the models that they have. They're very informative.